Good evening, ladies and gentlemen. It's a pleasure to be here with you this evening to discuss the topic of pre-gestational diabetes. And this is a very important topic because many patients with diabetes plan pregnancy and undergo pregnancy. And therefore, it is important to understand how best to manage these patients. So for the purpose of this presentation, I will only talk about diabetes that is diagnosed before pregnancy. So pre-gestational diabetes is diabetes that is, as far as this presentation is concerned, diagnosed before pregnancy. And I will discuss the pre-pregnancy planning of the management of this diabetic patient with a focus on glucose control. Now, hyperglycemia or high blood glucose, which is detected at any time during pregnancy, can be classified either as gestational diabetes or pre-existing overt diabetes, because you find out a high blood glucose in pregnancy. Now, that could either be a pre-existing diabetes or gestational diabetes, but that is not something I'm going to discuss in this webinar. In this webinar, I will discuss a type 1 or a type 2 diabetes, a lady who is already diagnosed and is now planning pregnancy. So as I said before, pre-gestational diabetes and gestational diabetes are two different categories, and I will talk about pre-pregnancy planning. I'd like to just show you this slide, which looks at the prevalence of diabetes in pregnancy and also discusses what proportion of people who have diabetes in pregnancy actually have gestational diabetes and how many of them have pre-gestational diabetes. So for all the diabetes in pregnancy, about 13% of them have pre-gestational diabetes. And if you look at all patients with pregnancy, about 1% would be the prevalence of pre-gestational diabetes. The prevalence of gestational diabetes in India has been about 9%, but as I said before, I would only be talking about pre-gestational diabetes, which actually occurs for only about 1% of all pregnancies. Now, in this slide, which I'm putting up, I'm just showing you the agenda for my presentations today, which is to discuss pre-gestational diabetes under 5 headings. The first heading is why we should treat hyperglycemia. The second heading will be what are the targets? Is treatment going to be effective? How should glucose be monitored? And finally, what are the treatment options? Let's look at the first topic of the agenda, which is why should we treat hyperglycemia? Now, it is very important to achieve normoglycemia in pregnancy because in early pregnancy, the risk of miscarriage, the risk of malformations are all highest when the blood sugar or the average glucose is more than 180. And the HbA1c of more than 8% increases the risk of miscarriage and birth defects. So it's very important that treating hyperglycemia and achieving normoglycemia is important. And the reason why we are worried about treating hyperglycemia is because of the risk of malformations, the risk of miscarriage, and the risk of macrosomia. So there are 3 M's, if you like: malformation, miscarriage, and macrosomia. And there are also some other issues which can occur in pre-gestational diabetes when they become pregnant, and that is preeclampsia, perinatal mortality, proteinuria, and of course preterm delivery. So 4 P's, if you like: preterm delivery, perinatal mortality, preeclampsia, and proteinuria, of course, which is part of the preeclampsia-eclampsia syndrome. So therefore, it is very important to treat hyperglycemia and achieve normoglycemia in pregnancy. There are, of course, other complications that can occur in pre-gestational diabetes when they become diabetic. And one important one is diabetic ketoacidosis, because the prevalence of placental hormones and other hormones increasing in pregnancy would heighten the risk of diabetic ketoacidosis, and some complications of diabetes can actually worsen. For example, retinopathy can worsen, proteinuria and hypertension pre-existing can worsen. It's been well shown that patients who have diabetes and microalbuminuria or even macroalbuminuria prior to pregnancy, there is a risk of preeclampsia which actually goes up. I just want to focus a little bit on macrosomia, because macrosomia is something important, and macrosomia increases the risk of shoulder dystocia in pregnancy. In general, we define macrosomia as a weight of more than 4 kilograms after the 37 weeks of pregnancy. But I'm an endocrinologist, and gynecologists and obstetricians will be able to discuss this further. I will soon discuss in a set of slides as to how macrosomia occurs, but I just want to say that about 15 to 45% of diabetic pregnancies actually have macrosomia, and 1 out of 4 macrosomic babies actually have shoulder dystocia, and of course the need for cesarean section. So I've looked at why we should treat hyperglycemia. Now I come to the second part of my for the agenda for this lecture, which is if we decide to treat hyperglycemia and if we decide to achieve normoglycemia, what should be our targets? And again, I'd like to put up this slide for you to look at, which looks at the targets of glycemic control in pregnancy. There is some controversy out here, so I will discuss the controversy as well. The fasting glucose, I have set the target as 70 to 95. I'm using the word I've set the target because that's what the ACOG says. But if you look at the American Diabetes Association criteria, the targets for fasting glucose in pre-gestational diabetes is 60 to 90. I personally feel that 60 to 90 is very aggressive, so therefore I've looked at 70 to 95, or rather 70 to 92 milligrams per deciliter if you like. And that's a fasting pre-breakfast value. The pre-meal value I've kept it at below 100, and this is, the references are given below. The 1 hour post-meal should be below 140. The 2 hour post-meal should be below 120 milligrams per deciliter. The HbA1c, which is a 3-monthly index of glucose control, I have, I'm suggesting that we keep it below 6%, but there are some caveats. The Endocrine Society recommends keeping it below 7%, and even, if possible, below 6.5%, so that 6% is not a holy grail or set in stone, and somewhere below 7% would be quite acceptable. But if you look at very ideal situation, yes, below 6% is a very ideal situation. If you look at the late night time readings, that is hypoglycemia, which you need to avoid. So at about 2 to 3 a.m., you need to avoid hypoglycemia and keep the blood glucose levels more than 60 milligrams per deciliter. And at any stage, the mean glucose levels should be 110 milligrams per deciliter. And as I said, this lecture will focus on prenatal glucose control in type 1 and type 2 diabetes. And the guidelines are given below, the references. And again, I show the slide which shows the effect of HbA1c during pregnancy. And you can see that in the first trimester, the HbA1c starts coming down. In the second trimester, it's down there. And the third trimester, the HbA1c increases. Now, that's because in the first trimester itself, pregnancy is a state of heightened body activity. And the bone marrow also produces a lot of new, fresh, young little RBCs. And remember, the HbA1c is a marker, or it is determined by the mean RBC age. And when you have a lot of random red blood cells being produced, the mean red blood cell age actually comes down, and therefore the HbA1c actually starts coming down. In the second trimester, because of the fluid expansion that occurs in pregnancy, the HbA1c keeps coming down. But by the time one reaches a third trimester, because the RBC age is increased, the HbA1c starts coming up. So how do you interpret the HbA1c in pregnancy? A rough rule of the thumb is that the HbA1c is lower by about 0.4%, or rather percentage points, in a later pregnancy. And that HbA1c is a good indicator, not really of fasting blood sugar, because that can go down, but a good indicator of the post-meal hyperglycemia. And as I had said, the Endocrine Society in the US recommends a goal of below 7%. But ideally, people believe it should be kept below 6.5% well before pregnancy and during pregnancy. So I've looked at why we should treat hyperglycemia because of the 3 M's and the 4 P's. I've looked at targets which suggest that one needs to keep the fasting somewhere between 70 to 92, and the 1 hour and the 2 hour values, post-meal values, below 140 and 120, and the HbA1c as close to 6% as possible, but at least below 7%, and if possible, as close to 6% as possible. On that note, I'd like to look at my next aspect of my lecture, which is to actually tell you that is the treatment effective? And in order to discuss whether treatment is effective, I'd just like to put up this data slide, which looks at whether treatment is effective. I hope you can now see this slide, which is a very interesting study published in Diabetes Care 2011. And it looks at the odds ratio, just one outcome actually, preeclampsia, for each 1% decrement in HbA1c before pregnancy. And you can see that in the first antenatal visit and in the 34 weeks gestation, the adjusted odds ratio was 0.76 and 0.58. And that was statistically significant, as you can see by the p-value, which was less than 0.05. Now, how do you interpret this slide? Very simply, an odds ratio below 1 indicates protection and above 1 indicates risk. And an odds ratio that is below 1 and statistically significant indicates significant protection. And this slide very simply shows you that keeping the HbA1c lower by about 1 percentage point will actually reduce the risk of preeclampsia by approximately 30%. So that it really shows a profound effect. And again, I'm showing you the next slide. And this is a very, very busy slide showing you that euglycemia can improve outcomes. But this is one really important slide. In the very left-hand panel of the slide, you can see the HbA1c. And the HbA1c from top to bottom actually decreases. Or rather, if you look at the HbA1c from the bottom to top, it actually increases. And what is evident is that when the HbA1c increases from 6.9 to 10, the prevalence of congenital malformations, the relative risk, rather not the prevalence, relative risk versus the background population has almost more than doubled. From 1.4, it has gone up to 3.9. Similarly, the risk of perinatal mortality, when you look at an HbA1c of less than 6.9 to an HbA1c of more than 10.4, the perinatal mortality has also more than doubled from 2.8. The relative risk for perinatal mortality has gone up to 7.3. And the risk of any serious adverse event, if you look at the relative risk, has again more than doubled from 1.6 when an HbA1c is below 6.9 to 4.7 when an HbA1c is above 10.4. And this is data from 933 women with type 1 diabetes. And this shows you very exquisitely the effect of increasing HbA1c levels on a worsening outcome with respect to congenital malformations, perinatal mortality, and any serious adverse outcome. Therefore, ladies and gentlemen, major congenital abnormalities may occur in as high as 6 to 12% of diabetic pregnancies. Now, when the HbA1c is about 10%, there is a very, very high fetal anomaly rate of about almost 20%. But when you can bring the HbA1c to below 6%, when you can bring it to below 6% or close to 6.5 or below percent, 6.5% or so, the fetal malformation rate comes down to as close to normal pregnancy, so about 2 to 3%. That shows you this slide, which is based on this data, which is based on the ACOG Committee on Practice Bulletins published in the Journal of Obstetrics and Gynecology in 2005, actually shows you the importance of glucose control and HbA1c reduction on perinatal and fetal complications. So we've looked at why we should treat hyperglycemia. We've looked at what are the targets. I've shown you very, very convincing data, extremely convincing data that control of blood glucose is effective. Now we go on to the fourth point, which is how are we going to monitor the blood glucose levels? And that, again, I'd like to show you this interesting slide, which looks at a continuous glucose profile of a patient with type 1 diabetes and pregnant. So that type 1 pregnancy should actually read as type 1 diabetes with pregnancy. You can see on the slide a nice green band. That green band shows you approximately the normal glucose levels as far as the machine is concerned. And the black arrows actually show you at what are the times it is recommended to check blood glucose levels using a capillary glucose meter. So the times are 3 a.m. and you need to keep the blood sugar above 60 at 3 a.m. Then the fasting, 1 hour post meal. You could also do a 2 hour post meal, but a 1 hour post meal is quite good. And then, of course, prior to any exercise or any hypoglycemic symptom. And when I say fasting and post meal, it could be pre-meal and post meal for all the 3 meals of the day, and of course at bedtime. So this is just a rough slide. It shows you a continuous glucose monitor, but it also shows you the time in the monitor reading at which time one should check with a glucose meter. So any patient with type 1 or type 2 diabetes planning pregnancy, these are the times at which the patient should pull out a glucose meter and check the capillary glucose readings. And this is as per the American Diabetes Association recommendations. Now I'd like to show you this slide, which looks at the deterioration of retinopathy in pregnancy. And this is a problem with not just intensification of treatment, which is also a problem with pregnancy. We know that in diabetes, there is microvascular damage, which means that the small blood vessels to the kidney, to the eyes, and to the nerves of the feet are affected. We know that this affectation leads to retinopathy, neuropathy, nephropathy. So, but in early stages, these micro damaged little vessels are still patent. But when the effect of pregnancy comes into play, pregnancy is, as you know, a slightly hypercoagulable state because of the hormones. The narrowed but patent vessels can get blocked. And this slide shows you in the blue skyscraper, patients without retinopathy, 10% can progress to some form of retinopathy. In the gray or black skyscraper, patients with mild retinopathy, 21% can actually progress to a more severe form of retinopathy. And patients with severe NPDR, about 55% can progress. Therefore, progression of retinopathy is an important problem. So we come to the end of that slide, and now I'd like to show you that, tell you that the American Diabetes Association recommends that you need to check the retina before pregnancy, during the first trimester, during the second trimester, third trimester, 1 year postpartum, or as per the ophthalmologist's discretion. Now, some guidelines of the American the position statement says that you need to check it every 6 months in pregnancy. So that's fine. I think the important thing is you need to check for retinopathy in pregnancy. There are a few things which a woman with pre-existing diabetes, when she plans pregnancy, should make a rough checklist. And I'm just going to tell you about what is a preconception checklist for patients with pre-existing diabetes. I think the first and the most important is to achieve an A1C goal of 7%, or if you can achieve a lower HbA1c goal without hypoglycemia, below 6.5 or as close to 6%. Because remember, when diabetes happens, you have high blood sugars, but when a diabetic patient becomes pregnant, so that HbA1c can go up further. So therefore, if you reach an HbA1c of 6, even the diaberogenic effect of pregnancy may push it up to 6.5, but still you are safe. So the first thing is to achieve a good preconception HbA1c of below 7%, at least below 7%, but ideally below 6.5 or close to 6%. Second is to assess and manage any diabetes-related complications before pregnancy, which means looking for neuropathy, nephropathy, retinopathy, coronary disease. Thyroid dysfunctions also should be checked in women planning pregnancy. The third thing is, of course, I'm going to discuss in the slides to come, which is a treatment, which is to switch to insulin. The fourth thing is to give folic acid 5 milligrams per day, 3 months before conception to about 12 weeks post-conception. And of course, then to discontinue potential embryopathic medicines. I'd like to say that diabetes itself causes embryopathy, and that's probably because of the effect of hyperglycemia on microvascular disease, and the microvascular disease and other milieu affected by hyperglycemia can cause diabetic embryopathy, and that is manifested by the various malformations, the cardioskeletal, spinal manifestations, etc. But at the same time, the malformations, but at the same time, you need to discontinue certain embryopathic drugs, which a diabetic patients may be taking. So you need to discontinue ACE inhibitors, you need to discontinue ARBs. So how would you treat hypertension that pre-exists? You may have to give methyl dopa, you may have to give long-acting calcium channel blockers, you may have to give even beta blockers. And statins should be discontinued. So the 5 points in the checklist: attain an HbA1c below, which is appropriate, below 7 or close to 6.5%, to assess and manage any complications. 3, switch to insulin. 4, give folic acid. And 5, discontinue embryopathic medicine. These are the 5 checklist points which broadly summarize patients who are planning pregnancy. And finally, I come to the treatment. So we've looked at why we should treat hyperglycemia, and I've discussed all the reasons why we should treat. We've looked at the targets. We've looked at whether treatment is effective. We've looked at how often to monitor. Now we briefly look at the treatment options for pre-gestational diabetes. I'd like to put up this slide, which is an animation which shows you actually how glucose and insulin play out in a diabetic pregnancy. Remember, insulin really can't cross from the mother to the fetus, but glucose crosses from the mother to the fetus. Therefore, if insulin production is not enough, or when insulin action is not enough, the mother's blood glucose levels go up. So this slide says mother's blood sugar levels, but I really mean the mother's blood glucose levels goes up. And when the mother's blood glucose level goes up, too much glucose will cross from the maternal side to the fetal side. And when too much glucose crosses to the maternal to the fetal side, the fetal insulin production goes up. And because the fetus insulin production goes up, the fetus becomes macrosomia, or a large sized baby. So that's how gestational or pre-gestational or uncontrolled hyperglycemia or high glucose in the mother can actually cause macrosomia in the fetus, because insulin can't cross, glucose can cross, and the glucose crossing into the fetus causes fetal hyperinsulinemia. Insulin is a growth factor and causes macrosomia. Now let's look at the other situation. We all know that insulin can't cross, but the glucose crosses the placenta. What if you give too much insulin to the mother? Well, if you give too much insulin to the mother, the maternal glucose comes down. And when the maternal glucose comes down, less glucose is available to cross from the mother to the baby. So less glucose available to cross from the mother to the baby means two things. One is that glucose itself as a nutrient is less available. Second is that low glucose means less insulin and less growth factors. Therefore, the baby can become small for gestational age. So this slide shows you that the prevalence of macrosomia, or a large for gestational age baby, goes up when the mean blood glucose goes up in the mother. And when the mean blood glucose goes down, the prevalence of small for gestational age goes up again. So therefore, high blood sugar, high prevalence of large for gestational age or macrosomia, low blood glucose, small for gestational age baby, and therefore you need to maintain a glucose reading of about 100-110 mean average glucose reading for optimal benefit. I'd like to go back and stop sharing the slide and discuss some dietary aspects with you. Now, the caloric requirements are increased by at least 300 kilocalories per day in singleton pregnancies. In twin pregnancy, you have higher calorie requirements, higher weight gain targets. Of course, very rapid and excess weight gain means a large for a gestational age baby. And the role of weight loss is actually controversial. If you look at the proportion of diet, I think India is a country where we eat a lot of carbohydrates. So carbohydrates should still have about 50% of the diet. Protein, about 20% of calories could come from protein, and fat about 30%. Again, saturated fats should be very, very low intake. And of course, trans fats to be avoided altogether. If you look at the calorie distribution, 15% of the calories should come from breakfast, 25% with lunch, 30% with dinner, and the other 30% as snacks. So 15% with breakfast plus 25% with lunch is about 40%, plus again 30% with dinner is about 70%. And again, so 70% plus 30 is 100, the final 30 being the snacks. There is one clinical practical tip which one may need to remember, is that nocturnal hypoglycemia is very common, especially in the first trimester. So a bedtime snack is a good addition to add on to prevent nocturnal and early morning hypoglycemia. If you look at some guidelines, they allow non-caloric artificial sweeteners in pregnancy, but I would say that if it's possible to avoid artificial sweeteners completely in pregnancy. And so that's about diet. And about exercise, 30 minutes of moderate intensity exercise on most days, if not contraindicated by the obstetrician. So I leave the decision to the obstetrician, but 30 minutes of moderate intensity exercise, not involving the abdominal muscles, maybe involving the walking or something like that, would be good. So pre-gestational type 2 diabetes is associated with obesity. And recommended weight gain during pregnancy could be 7 to 10 kgs for overweight women and about 4 to 8 kgs in obese women. Obese women should actually put on less weight as overweight women. And the best choice for treatment, when we come to the treatment, when we look at medication, the best choice of treatment in pre-gestational diabetes, which is type 1 or type 2 diabetes, is insulin, and it's intensive insulin. Oral agents may have a role in gestational diabetes, but little role in pre-gestational diabetes, but some role in some selected settings, because you can use metformin in polycystic ovarian disease patients who go on to become typeric and type 2 diabetes coexisting. But largely, insulin is the best choice for treatment. And what is the insulin that should be given? I think multiple dose of short-acting insulin 3 times a day and a long-acting insulin. That's called basal bolus therapy, because in the normal human body, you have insulin throughout the day, which is basal insulin. With each meal, you can give a bolus, which is called a bolus insulin. Now, if you look at the good choices for basal insulin in a pre-pregnancy diabetes setting, is detemir insulin or NPH insulin. These are good choices for basal insulins. And of course, the prandial insulins, you can use regular insulins, but to minimize postprandial hyperglycemia, aspart, which is a rapid-acting analog, and lispro, which is a rapid-acting analog, are good. Now remember, NPH, detemir, aspart, lispro, all these insulins in pregnancy are category B, which means that animal studies have failed to demonstrate a risk, but there are no adequate and well-controlled studies in pregnant women. And glargine and blue lysine, probably glargine, is actually category C, which means that animal studies have shown adverse effect, and there are no well-controlled studies in humans. But sometimes potential benefits, when they exceed the risks, you might warrant the use of the drug. For example, somebody on glargine who has now become pregnant, you may like to continue it, but wherever possible, before pregnancy, switch the patient to a basal bolus insulin. The basal could be either NPH given twice daily or detemir, and the bolus with each meal could be a regular insulin or preferably an aspart insulin, which is a rapid-acting analog, or a lispro insulin. I'd like to just put up this slide because it is a complicated slide, and this slide shows you, the insulin requirements in pregnancy. And I'd just like to clarify that this is not for gestational diabetes or diabetes detected in pregnancy, because that's not the focus of my talk. This is only for pre-gestational diabetes. And I've divided into pregnancy into 3 trimesters. You can see 3 boxes there, less than 13 weeks, 13 to 28 weeks, and more than 28 weeks. And this is again for type 1 diabetes who become pregnant. And you can see that it's very easy to remember the first trimester, second trimester, and third trimester. The insulin requirements are 0.7 units per kilogram per day, 0.8 units per kilogram per day, second trimester, 0.9 units per kilogram per day, third trimester. So 0.7, 0.8, 0.9. Now this is for type 1 diabetes. Remember, type 2 diabetes patients have insulin resistance. They may have obesity. They may require larger doses of insulin. So they may require up to 1 to 1.6 units per kg per day as very early on. So for example, if you have an 80 kilogram lady, she might require 80 units a day, and half, 40 units could be given as basal, which means NPH 20 units morning and evening, and half as approximately as bolus, which means the other 40 given 3 times a day. And very, very obese patients may require up to 1.5 to 2 units per kilogram per day. That slide should read as 1.5 to 2 units per kilogram per day, not 1.5 to 2, but 1.5 to 2 units per kilogram per day. And therefore, average in pregnancy, the dose in type 1 diabetes could increase by about 52 units. In type 2 diabetes, the requirement may be very high. Again, I'd like to show you this slide. This is a pictorial slide which represents that in the normal body, you have insulin throughout the day and 1 insulin with each meal. And insulin pump therapy is nothing but an advanced form of basal bolus therapy, where a pump delivers insulin, and the pump delivers insulin to just under the skin throughout the day. And therefore, I'd just like to show you this slide again. I'd like to just share this slide, which is a slide of insulin pump in a patient who is type 1 diabetes and is also on a continuous glucose monitor. This is taken just 2 months ago. You can see it's in April. in 2016, just taken 2 months ago. She is a type 1 diabetes patient on insulin pump who has become pregnant. So really, insulin pump is a very, very expensive treatment in India, and you don't need to actually put every diabetic pregnancy on insulin pump. It's a very, very rare, complicated, expensive form of therapy. But if a type 1 diabetes is already on an insulin pump and becomes pregnant, you would like to continue the insulin pump therapy. Insulin pump is an excellent form of controlling diabetes, but it's very, very expensive. So we can't recommend it to a resource poor country like ours. But in this slide, you can see that there are several lines of different colors. And you can also see the green band. So any dot above the green band suggests a high glucose level. Any dot below the green band suggests a low glucose level. And you can see that repeated chances of hypoglycemia that occur during pregnancy. And you can see on each day of the week, for example, I think if and the Friday, it's a red color, and you can see yellow color is for Monday. So each day you have a different blood sugar reading. Largely, the blood sugar of this patient is doing reasonably well because it is a very difficult to control type 1 diabetes patient. And as you can see in this slide, this shows you insulin pump and a continuous glucose monitor, a Dexcom glucose monitor in pregnancy. You can see the average glucose level of this patient is extremely good, 104, and you can see in the panel the hours from 0 hours to 23 hours. So all the 24 hours of the day, the blood glucose levels quite a good average glucose about 104. So very difficult to maintain this and keep it, but this patient managed to maintain it on insulin pump therapy, and this was done when she was pregnant. So insulin pump therapy, a good form of giving insulin to a type 1 diabetes patient who has become pregnant, but obviously very costly in India. So what is the role for oral drugs? I think insulin is ideal. Metformin can be used as an adjunct or an alternative to insulin. Now, metformin can be used when insulin doses go up, or in very mild cases, you can actually use metformin, but usually you will require insulin in almost all cases of pre-gestational diabetes. Metformin is especially useful in patients with polycystic ovarian disease who become pregnant. Now, I'd just like to give a small disclaimer here, because I have told that basal bolus insulin is the ideal form of insulin therapy in pre-gestational diabetes. In gestational diabetes, which I'm not covering actually, you may require only parenteral insulin. But where you require very, very small doses of insulin, there may be a role for premix insulin as well. So a large majority of patients with pre-existing type 2 diabetes will require basal bolus insulin. A small minority may be managed from premixed insulin. But I can tell you that almost all pre-gestational type 1 diabetes patients, almost all of them will require, not almost all will require, type 1 diabetes becoming pregnancy will require a basal bolus insulin or even sometimes occasionally pump therapy. While there is some data to support glibenclamide, because it is among the sulfonylurea oral drugs, it is got the least transfer across the placenta. Remember, the studies of glibenclamide was done in gestational diabetes, and that means that diabetes was diagnosed well after the first trimester and the second trimester, and therefore there is very little data on glibenclamide in the first trimester. And first trimester is a state where fetal organogenesis occurs, and therefore I would not use any other oral pill other than metformin in pregnancy. I would not use glibenclamide, though there is some data to support. I would not use acarbose. I would certainly not use thiazolidinediones or any other form of therapy for diabetes, pre-gestational diabetes. In the first trimester, there can be a decrease in the total daily dose of insulin, increase in risk of hypoglycemia, which may not be good. It can cause intrauterine growth restriction, as I showed you in an animation, and therefore you need to be careful. In the second trimester, you have insulin resistance coming in because of the placental hormones, the fetal hormones, the estrogen, progesterone, and other hormones. So you might see that insulin requirements actually double or triple. So you may have to aggressively increase the dose in pre-gestational diabetes weekly or bi-weekly. As pregnancy progresses, you might have to decrease the basal and increase the prandial component. Remember, first trimester and especially mid-trimester hyperglycemia. Mid-trimester hyperglycemia is a very important predictor of fetal macrosomia and can be corrected by intensive glucose control. Now, what happens during pregnancy, during labor? That is intrapartum management. Intrapartum glucose control is important because neonatal hypoglycemia can occur. Insulin resistance rapidly goes off with the delivery of the placenta. sudden decline in insulin requirement occurs. So you can give some IV short-acting insulin, you can give intravenously as an infusion for intrapartum control of glycemia, but you will see that the insulin requirement rapidly comes down, even in type 1 diabetes, even in patients who require pump. Once the delivery occurs, the insulin requirement comes down. So you might like to keep the blood glucose levels during labor somewhere between, say, 100 to 180 milligrams per deciliter. So therefore, it's also important to remember that a baby of a diabetic mother may have complications like neonatal hypoglycemia, erythrocytosis, acute respiratory distress syndrome, hyperbilirubinemia. So these all need to be managed by a pediatric intensive care specialist intensivist. Postpartum management is again that insulin requirements decrease after delivery. In fact, in a type 1 diabetes, the insulin requirement is approximately 50% of that during pregnancy. After delivery, if patient is on 80 units per day, it might come down to 40 units per day. In type 2 also, the dose comes down. In a type 2 diabetic, though I don't really use it, you can use glibenclamide and metformin. Metformin, of course, I have used in patients during lactation, and you can use metformin safely during the lactation period. And of course, breastfeeding should be encouraged. I would not have to say that to such an enlightened audience, but in the pregestational diabetes as well, you need to encourage breastfeeding. So, ladies and gentlemen, I have come to the second last slide of my talk, and I have discussed the 5 points: why we should treat hyperglycemia, because of the 4 P's and the 3 M's. What are the targets? I've looked at fasting, which is below 92, the post meal 1 hour below 140, the HbA1c as close to below 6.5%, ideally as close to 6%, below 6.5% if possible, without hypoglycemia, at least below 7%. Is treatment effective? Yes, it is. It has been shown to reduce preeclampsia, malformations. How should glucose be monitored? It should be monitored using a glucose meter. I've discussed the timings of the day. What are the treatment options? Insulin, of course, in different methods, the ideal treatment option. I just would like to put up my last slide, which is to thank you for listening to me. And I'd just like to put up that slide, which also shows my Twitter address. So in case you have any questions, which we may not be able to discuss for paucity of time, I'd like you to contact me on Twitter if you wish to discuss. Ladies and gentlemen, thank you for listening to me. It's a pleasure. So you can now pull down the slide and then we can see it. So I think one of the important questions is that what is diabetic embryopathy, and does it have a link to oxidative stress? I think that's a very important question, because if you look at diabetic embryopathy, people believe it's a microvascular disease, but it may not be actually a microvascular disease. There are other factors such as oxidative stress and the hyperglycemic milieu of pregnancy, ketone body production. All these may come into play. But yes, oxidative stress is probably an important contributor to diabetic embryopathy, and people have debated the role of certain kinases, enzymes, and some effect of hyperglycemia on genes as well, and epigenetics, but we are not sure. But yes, oxidative stress seems to contribute to diabetic embryopathy. Then there is a question here: in early stages of diabetes, physicians have prescribed glimepiride, pioglitazone, and metformin, and the early fasting reading is 138 and 216. What is your opinion? I am asked. Well, I think insulin should be given well before pregnancy. Any diabetic patient who's actually planning pregnancy, I tell them 3 months before you stop all the oral drugs, put yourself on insulin, get that HbA1c to about 6% if possible, and then plan pregnancy. Take some folic acid, work yourself up for complications. Don't get worked up, but work yourself up for complications. And I think glimepiride, I would not use it in pregnancy. Pioglitazone, certainly not, because pioglitazone may actually cross the placenta. People are not sure whether it does, but it can decrease insulin levels. And there are some animal studies which have shown, if I remember right, intrauterine growth restriction. And therefore, I think that question, I completely agree with you, Dr. Purnachandra Rao, who's asked that question, that we would probably use insulin in those settings. The question by Dr. Abhichandani was relating to oxidative stress and embryopathy, which I discussed, and he's also discussed in what are the key components of preconception diabetes management. So HbA1c under control, pre-evaluation for diabetic complications such as neuropathy, nephropathy, retinopathy, coronary disease, and thyroid, folic acid, and of course, avoiding diabetic embryotoxic drugs such as ACE inhibitors, ARBs, and statins to be stopped, and then shifting to other drugs. There is a question by Dr. Rao, Dr. Narayan Rao. How often do these patients go on to develop overt diabetes later in life? Now, I'm discussing pre-gestational diabetes here, which means that the patient is already having diabetes before pregnancy and is planning pregnancies. All of them will probably be on have diabetes continued even after delivery. But your question, I suppose, is gestational diabetes or diabetes diagnosed during pregnancy, which is in the gestational diabetes range. I think studies have shown that after about 10 to 20 years after delivery, about 20 to 30% of the person will develop type 2 diabetes, and therefore you need to have some diabetes prevention program for them as well. Next question is by Dr. Manjusha. Is this related to increasing maternal age? Yes, maternal age will increase the risk of gestational diabetes. Dr. Vinod Abhishandani asks, can we measure HbA1c monthly by acknowledging the second and third trimesters are less reflective of tight glucose control? I completely agree with you that if we know the limitations of HbA1c, the fact that the first trimester, the average age of the RBC comes down. In the second trimester, you may have fluid expansion. In the third trimester, the HbA1c may improve. And if we assume that the HbA1c may be about 0.4% different, when we understand all the caveats in HbA1c, then I think if you use HbA1c to monitor, it may be effective. And we have used HbA1c a couple of times in patients on the type 1 diabetes going on for insulin pump therapy, and we found it to be quite a good marker. So there is a question here from Dr. Gulati. What label to be given to females with blood glucose levels of 140 to 199 in the first trimester, GDM or type 2? Well, now, again, I'm talking only about pre-gestational type diabetes, which is largely type 2 or type 1. But if a patient is not diabetic, becomes pregnant in the first trimester, you do a GTT. What I like to do is a 75-gram GTT, and I check at 0, 1, and 2 hours. I look at values of 92, 180, and 153 at 0, 1, and 2 hours, and take two values as being abnormal. I think if the fasting is more than 126, then you are dealing with overt type 2 diabetes. Whereas if the fasting is 92 to 125, you are dealing with gestational diabetes. Similarly, if the post-glucose is more than 200, you are dealing with overt type 2 diabetes. Anywhere 148, 199, it's probably gestational diabetes. Now, these are all semantics because the targets are likely the same. Dr. Mahinder Singh asks, what is the target level of blood glucose levels to be maintained in pre-gestational diabetes? What is the target postprandial levels? Is it possible to keep at pre-diabetic level even during pregnancy with diet and exercise and medication? Yes, the target level of fasting blood glucose, if you look at the American diabetes criteria, is about 60 to 90. But in my slide, I have used 70 to 95, which is a different criteria because I acknowledge that it is very difficult to achieve that kind of blood sugars without hypoglycemia. 70 to 92 is what I 70 to 92 is what I had recommended. The American Diabetes Association criteria is 60 to 90, and I really leave it to your choice. If you can achieve a good HbA1c without hypoglycemia, an HbA1c of 6, excellent. But we all know that it's good to talk about or give talks about, but in practice, very difficult to achieve HbA1c of below 6% in the Indian setting. And that's a limitation we face because Indian patients are resource limited. They're not willing to do their glucose meter tests 6-7 times a day. Though I have patients the occasional motivated patients who can do it, but we struggle to motivate them, and also the economics of glucometer testing so many times a day. And if you don't do enough tests, and if you just try to achieve targets, you are going to land up in hypoglycemia. So I would answer that question saying that the target post-meal 1 hour level is about 140, 2 hours about 120. And it is, you have asked whether we can keep it at pre-diabetic levels. We can, if we have a really motivated patient who's really going to do the glucometer, really test 6 times a day. But it is difficult. But if you can, fantastic. I think there will be a lot of questions coming, and I'm delighted actually. And how often should blood glucose be monitored in diabetes taking injection as part for gestational diabetes? Well, the recommendations are that you should test 7 to 9 times per day. So that is the actual recommendation. That means fasting before each meal, 1 hour after each meal, at bedtime, 3 a.m. Yes, the occasional motivated patient does all these values. Where cost is a concern, even buying a glucometer strip is a concern for resource-limited Indian patients. I tell them at least test 3 times a day if possible, at least once a day. Some monitoring is better, and we'll have to look at our targets practically. What is the ideal HbA1c target below pre-gestational diabetes? Well, I think that question by Dr. Govindarajan is also a question which is something which I have slightly been ambiguous about, because I've talked about three criteria. I've looked at HbA1c below 7, 6.5, and 6. Which one would I choose? I would choose below 7%, because that is what the Endocrine Society recommends. US recommends below 7%. But if I could have a motivated patient who's willing to keep it below 6.5% or close to 6%, why not? That's a broad number to remember. 7% is what the Endocrine Society of the US recommends. I think there are more questions coming in. What is the reason for sudden intrauterine death in diabetes? Well, we are not sure why there is sudden intrauterine death in diabetes. People believe it is because of the effects of hyperglycemia and effects of hyperglycemia on the vasculature. But again, we are not very sure. There are several mechanisms. Any comments on fructosamine assay? Well, it is available. It is expensive, but it is not routinely available. I haven't used it. Thank you for asking that question, Dr. Seema Advani. Dr. Rajshekhar, does the concept of glycosylation endpoints responsible for diabetic food and other diabetic complications valid since the pathophysiology of the disease? I think this is not a question that is related to pregnancy, but I'd like to still answer that question because it is a felt need for all of us doctors to understand why there are diabetic complications. And therefore, when you have glucose bound to proteins, this binding is earlier reversible and then becomes irreversible. And advanced glycation end products are basically, glucose binding to proteins and glycation occurring, and those end products are supposed to cause complications. Yes, they are reflective of complications, especially diabetic foot, diabetic retinopathy, microalbuminuria. Well, are they the only important factors? We don't know, because HbA1c is a glycated product and it's not 100% reflective of complications. It is. So we've also recently published in a journal of clinical proteomics looking at other markers which could also reflect hyperglycemia and also reflect complications. Yes, we require more markers, but for the moment, advanced glycation end products do explain diabetic complications very well, and glycation inhibitors offer promise. Again, this question is not related to diabetic gestational diabetes or pre-gestational diabetes. It is a question for diabetes in general. There is one more question by Dr. Vinod who asks, how would you define hypoglycemia in pregnancy? And how would you define hypoglycemia in the pre-pregnancy state? Now, that's a very interesting question. Now, before pregnancy, in a non-pregnant person, you define hypoglycemia as a blood glucose level of below 70. But in pregnancy, you define hypoglycemia as a value below 60. Now, why is that? That's because in pregnancy, you have counter-regulatory mechanisms coming in at a lower range. And traditionally, we define hypoglycemia based on counter-regulatory hormones. What are counter-regulatory hormones? Well, if you've not eaten for a long time, of course, I've had my lunch, but if you have not eaten your lunch, and if you are still feeling hungry, at a particular sugar level, you will have a release of hormones like glucagon, adrenaline, cortisol, growth hormone. These are called counter-regulatory hormones. The level at which these counter-regulatory hormones increase, that's usually set as a diagnosis of hypoglycemia. So in a non-pregnant adult, at a blood glucose level of 70 and below, you will have a good counter-regulatory response. But in pregnancy, it's as low as 60. And remember, in the first trimester, the blood glucose naturally falls down in the fasting state. So you are going to get, so therefore, in pregnancy, it's below 60. In non-pregnant people, it's below 70. And therefore, in pre-pregnancy, it should be below 70. And once patient becomes pregnant, the hypoglycemia should be below 60. Again, I would say achieve a target of 70 to 92. That would be a reasonable target to achieve for, because if you bring the blood sugars during to the closer lower limit of the normal, the chance of hypoglycemia goes up. Those are pragmatic suggestions from my side. I think, thank you. I've been overwhelmed by questions, and questions are still pouring in. And I've really liked talking to you because I have so many questions coming in, and that shows your interest. I would like to thank you for listening to me. It's a pleasure talking to you, and have a great day. Thank you very much.